Well, I'm glad to be giving another update on COVID-19 therapeutics for today's clinical forum. These are my disclosures. We've covered three major areas in COVID-19 therapeutics: small molecule antiviral drugs, passive immunotherapy, and immune modulators. Today, I'm going to focus on data on two immune modulators that have emerged over the last several weeks. The first is Tocilizumab. Tocilizumab is a monoclonal antibody directed against the IL-6 receptor, and it blocks the IL-6 receptor axis and therefore blocks signal transduction that leads to an inflammatory storm. We know that very high levels of inflammatory cytokines, including IL-6, are characteristic of the inflammatory phase of COVID-19. There have been many randomized clinical trials of tocilizumab, several of which we've discussed in previous episodes in this series. And these have given mixed results. This meta-analysis, published late last year, showed that on balance, there was a modest but significant impact of tocilizumab in preventing progression to mechanical ventilation, but not a benefit in terms of mortality overall. This analysis came out before the REMAP study was published. REMAP-CAP was a large randomized clinical trial that had many different arms, but two of those arms included an immune modulator arm in which participants could be randomized to placebo or tocilizumab, and then later placebo or sarilumab. And the study showed that in the primary outcome, which was the proportion of participants experiencing organ support-free days, that there were significant benefits to both tocilizumab and sarilumab. Importantly, there were also significant survival advantages for both drugs, with a 2/3 better survival for tocilizumab and a twofold greater survival for sarilumab, although the number of participants who received sarilumab was very small, and so it hasn't had as much of an impact on use of this agent in the treatment of COVID-19. Now, more recently, we've seen data from the recovery tocilizumab trial. As you may recall, the recovery trial is a very large platform study with multiple arms and multiple opportunities for randomization to different therapeutic interventions. In the tocilizumab component of that trial, recovery participants who had clinical evidence of progression were eligible for the tocilizumab component if they had an O2 sat that was less than 92% on room air or requiring supplemental oxygen to maintain that, and had a C-reactive protein level that was 75 milligrams per deciliter or higher. More than 4,100 participants were randomized equally to tocilizumab, which was dosed by weight or standard of care. And a second dose was given 12 to 24 hours later if there was no clinical improvement. The primary endpoint was 28-day mortality. This slide shows some of the baseline characteristics of the participants in this study, and I'll just highlight a few. First of all, the average age was just under 64 years. Participants had symptoms for 9 or 10 days and had been in the hospital for about 2 days prior to randomization. About 13 or 14% were already receiving mechanical ventilation. About 40% were receiving non-invasive ventilatory support, and about 45% required no support, meaning either they were not on oxygen or required only very low flow oxygen. You can see that the C-reactive protein was quite high, on average about 144, and small numbers had received dexamethasone or boosted lopinavir or hydroxychloroquine and so on as part of the initial randomization, but ultimately 80% or so of the participants had received systemic corticosteroids. These are almost entirely people who were randomized after July of 2020 when results of the other part of recovery that demonstrated the clinical benefits of dexamethasone had become available. This slide shows the primary outcome, which was, again, mortality at day 28. And you can see the tocilizumab group shown here in red had significantly lower mortality compared to the standard of care group. That was about a 15% reduction in the rate ratio. And if we look at the likelihood of being discharged alive, we can see here again the red line representing the tocilizumab group, showing significantly greater proportion of participants who received tocilizumab surviving to discharge, about a 22% greater rate of discharge. Looking across different baseline factors, we can see that the direction of the results favor tocilizumab regardless of age group, more prominent for men than for women. Didn't matter in terms of ethnicity. Perhaps a somewhat greater benefit for people who were had symptom onset less than 7 days prior to randomization compared to 7 days, but still both showing a benefit. And clearly benefits for those who did not require ventilatory support, and those who had non-invasive ventilatory support, not a significant benefit among those who were already receiving invasive mechanical ventilation. And then clearly a benefit for those who were receiving corticosteroids, and perhaps less evidence of benefit or no real benefit in those not receiving steroids. And it's important to remember that in the REMAP-CAP trial, the participants were receiving corticosteroids, and that's the context in which tocilizumab use is being considered. As part of this analysis, the recovery group did another meta-analysis looking at all of these studies, this time including the REMAP-CAP study. And we can see that recovery by itself shows here with about a 15% reduction in mortality, and that looking at all trials, there is about a 15% benefit. Those results obviously heavily weighted by both recovery and REMAP, which are far and away the largest of the trials. In addition, subsequent to the publication of the recovery tocilizumab trial just this week in JAMA Internal Medicine, Mariette and colleagues published an updated analysis from the core Immunotoci study, which is one of the studies that was included in those meta-analyses. And here what they did was a stratified analysis that looked at the impact of tocilizumab in people based on their entry CRP levels. You can see that in that study overall, there was no statistically significant benefit of tocilizumab. But if you stratified by CRPs that were above or below 150 mg per mil, recall in recovery, the average was about 144, that here for the solid lines, which represent the people with less than 150 mg per liter CRP, there's a reduction, but no statistically significant benefit for tocilizumab compared to the standard of care. However, in those who had the higher levels above 150, the dashed line, which is superimposed on the solid line here for Toci, is significantly greater than the dashed line for those who received usual care. And if we look down at the bottom here and look at the actual hazard ratios, we can see that for those who had CRP greater than 15 mg per deciliter, which is the same as 150 mg per liter, that there was about an 80% reduction in the hazard of progressing to requiring ventilatory support, and there was about a 20% reduction in the hazard of death. So these results strongly support the updated US Department of Health and Human Services guidelines for treatment of COVID-19 as they regard tocilizumab, which recommends use of tocilizumab in combination with dexamethasone in certain hospitalized patients who are exhibiting rapid respiratory decompensation due to COVID-19, including those who are recently hospitalized within 3 days, who've been admitted to an ICU in the last 24 hours and require invasive mechanical ventilation, non-invasive ventilation, or high flow oxygen supplementation, as well as recently hospitalized patients who may not be in the ICU, but are having rapidly escalating oxygen needs and require non-invasive ventilation or high flow nasal cannula oxygen delivery. Well, let's turn now to talk about baricitinib, one of the kinase inhibitors. Baricitinib is a Janus kinase or JAK1 and 2 inhibitor. It inhibits intracellular signaling of various cytokines that are elevated in severe COVID-19, and very much like tocilizumab is thought to interfere or moderate the cytokine storm. And it may also have some direct effects by inhibiting SARS-CoV-2 entry by inhibiting the AP2-associated protein kinase 1, which is implicated in viral entry. Now, we've previously discussed the ACT-2 study, which was a randomized double-blind trial in hospitalized adults with COVID-19 pneumonia and oxygen saturations that were less than 94%, representing severe disease. These participants were randomized equally to receive remdesivir or remdesivir plus baricitinib, with a primary endpoint of the time to recovery within 28 days. What the study showed was that there was a statistically significant benefit to receiving baricitinib plus remdesivir over remdesivir alone, as you can see in panel A. That benefit was limited to people who had more advanced disease. But we see that for those with an ordinal score of 4, which was really just receiving low flow oxygen, that there was no real benefit. But for those who were sicker, there was a benefit, and that benefit becomes even more pronounced in those who had an ordinal score of 6. Where 7 represents those who were intubated or receiving ECMO. Again, no benefit among the most severely ill, and this really highlighted the potential role of baricitinib in this fairly ill but not critically ill group of patients. So the COV barrier study is an independent global phase 3 double-blind randomized clinical trial that has just been reported as a preprint in medRxiv. It's not yet peer-reviewed and not yet officially published. This study had the eligible participants were 18 years or older and hospitalized with COVID-19. They had to have at least one elevated marker of inflammation. They could not be mechanically ventilated at the time of study entry. They were permitted to use steroids, which is a big difference from the ACT-2 study, which was done prior to the availability of the recovery dexamethasone results. The composite primary endpoint was the proportion of participants who progressed to high flow oxygen or non-invasive ventilation, invasive mechanical ventilation or ECMO, or death by day 28. So any of those 3 events would be a primary endpoint. And the study randomized a little more than 1,500 participants equally to either baricitinib or standard of care. The time frame here is important in terms of what other therapies might have been available. And so this study began in June of last year and concluded in January of 2021. Just under 2/3 were receiving supplemental oxygen and a quarter were receiving high flow oxygen. Nearly 80% were receiving concomitant treatment with corticosteroids. Interestingly, only 20% were receiving concomitant remdesivir, which makes this study very different from the ACT-2 study. This slide shows in table form the primary and secondary outcomes of greatest interest. So the primary outcome, of course, was this composite endpoint. And here there are 2 populations. Population 1 is the entire study population. Population 2 is the subgroup of participants who were receiving supplemental oxygen, but were not receiving corticosteroids, so a smaller group. And what you can see is that overall, for population 1, there is a 15% reduction in the occurrence of the primary endpoint, but this fails to achieve statistical significance. And you can see the p-value here. For population 2, those not receiving steroids, there really is no benefit, and that is not a statistically significant finding. However, in the pre-specified secondary endpoint of all-cause mortality, there is a substantial and highly significant benefit. There's about a 45% reduction in the risk of death, and that was highly statistically significant. So had this study been designed like recovery or like a remap cap and had mortality as the primary endpoint, this would have been a positive study. However, the pre-specified primary outcome was a composite endpoint, and the study failed to meet that primary composite endpoint at the level of statistical significance. If we look at different subgroups, we can see that regardless of the actual ordinal scale at time of study entry, 4, 5, or 6, recalling that this is here we're at high flow O2, 7 being mechanical ventilation, 8 being death, that there is a benefit regardless of baseline status. There was a benefit regardless of baseline steroid use. There was a benefit regardless of remdesivir use, although not significant for among those using remdesivir, remembering that's less than 20% of the population, and similar effects across geography and regardless of gender and also duration of symptoms. So it's not clear yet where this leaves baricitinib in terms of the overall approach to treatment of COVID-19. The DHHS guidelines have not yet been updated in light of these more recent data. It's likely they will wait until the data are peer-reviewed and formally published. And they currently state that there are insufficient data to recommend for or against the use of baricitinib. They do recommend the use of baricitinib in combination with remdesivir in those rare patients in whom corticosteroids cannot be used. And that's really based on the Act 2 trial and says that the drug should not be used without remdesivir. Now, these most recent data would require some reconsideration of both of these recommendations, since the Cove barrier study clearly demonstrated a benefit when used in combination with corticosteroids and when used without remdesivir. And the DHHS concluded that there were insufficient data to recommend for or against use in combination with corticosteroids. But as we've seen now with more data, this will have to be taken under consideration and potentially revised. So I'm happy to have brought you this most recent update and look forward to our discussion.